Hello, my name is Fred Locke. I'm an associate member and vice chair in the Department of Blood and Marrow Transplant and Cellular Immunotherapy at Moffitt Cancer Center. I'll be discussing an abstract that was presented at the ASCO annual meeting, virtual meeting in 2020, entitled Retreatment of Patients with Refractory Large B-cell Lymphoma with Axicabtagene ciloleucel in ZUMA-1. ZUMA-1 is the pivotal multi-center phase 1-2 study evaluating axi-cel, an autologous anti-CD19 CAR T-cell therapy in patients with refractory large B-cell lymphoma. Axi-cel is approved in the US and Europe for the treatment of patients with relapsed refractory large B-cell lymphoma with 2 or more prior systemic therapies. While axi-cel has demonstrated durable responses in a subset of patients, over half of all patients who are treated with this therapy eventually progress, and little is known about the efficacy of retreatment with CAR T-cell therapy. In cohorts 1 through 4 of ZUMA-1, there were 14 patients that received retreatment together with lymphodepletion chemotherapy. In this abstract at ASCO, we evaluated the outcomes in those 14 patients that underwent retreatment. 93% of patients who received retreatment had a response to their first CAR T-cell treatment, and the median duration of response was 3.3 months to the initial treatment. The objective response rate with retreatment was 57%, and response to retreatment was more common among patients who achieved a CR with the first treatment compared to those with a partial response or stable disease. While 6 out of 7 patients who achieved CR with first treatment responded after retreatment, only 2 out of the other 7 patients achieved a response with retreatment. The median duration of response with retreatment was 9.4 months, though this does include ongoing response after transplant in 4 patients. 2 patients remain in response 11 and 18 months after retreatment, the latter of whom did not receive transplant or any other subsequent therapy. The severity and incidence of neurologic events and cytokine release syndrome were lower with axi-cel retreatment compared with the first treatment. Notably, grade 3 neurologic events were seen in 50% of patients with first treatment and only 21% with retreatment. There were no grade 4 or 5 neurologic events following retreatment, nor any grade 3 or higher CRS. To investigate differences in efficacy and safety, we assessed product characteristics and differences in PK/PD profile from first treatment to retreatment. Retreatment axi-cel had 3 different source materials depending on the patient, with most products remanufactured from the original frozen peripheral blood apheresis. Across all patients, product characteristics were largely comparable between first and second axi-cel infusions, though there was a slightly higher transduction efficiency noted with the retreatment products. We did note that CAR T-cell expansion was lower after retreatment compared with first. Lower peak CAR T-cell expansion was paralleled by lower tumor burden at treatment compared to first treatment. And additionally, levels of key cytokines associated with response to CAR T were lower after retreatment compared with first treatment. Based upon this limited sample size, retreatment with axi-cel may have clinical efficacy in some patients with large B-cell lymphoma, especially patients who achieved complete response with their first CAR T-cell treatment. CAR T-cell expansion, serum cytokine levels, and severe CRS and neurologic events appear to be attenuated at retreatment, and durability of response remains to be determined as several patients received consolidative allogeneic transplant. We look forward to further studies with additional patients to confirm and expand upon these results.